Thank you for everyone for making it today. Welcome to OsteoBites. My name is Christina Iptoma, and I am mom to Osteo Angel Dillon, and also the Director of Scientific Programs for MIB Agents. And today on OsteoBites, we have a double whammy. We get to talk to both Dr. Kristen VanHeyst and Dr. Alex Huang, who will be providing an update on 2 clinical trials that are in development targeting tumor microenvironment in refractory and metastatic osteosarcoma. And thank you to Matt Allen, a member of our MIB Agents Senior Advisory Board, who is our panelist today. I am very excited to introduce you to our dynamic duo today. Dr. Huang is the director of the Center for Pediatric Immunotherapy in the Angie Fowler AYA Cancer Institute at Rainbow Babies and Children's Hospital, and the professor of pediatrics at Case Western Reserve University School of Medicine, and co-leader of Immune Oncology Program at Case Comprehensive Cancer Center. He also directs the Pediatric Hematology-Oncology Fellowship Program at Rainbow. So you can see we are really lucky that we got an hour out of his time today because he is a busy man. Dr. VanHeyst is an assistant professor of pediatrics at Angie Fowler AYA Cancer Institute at Rainbow Babies and Children's Hospital and Case Western Reserve University School of Medicine. And her research efforts focus on understanding the role of the tumor microenvironment in metastatic pulmonary osteosarcoma. Dr. VanHeyst has worked closely with Dr. Huang to bring a myriad of clinical trial options as direct translations from bench research to bedside. And before we get started, some upcoming events we want to just put on your radar. FACTO registration is now open, so check out, we'll put the registration link in the chat. It's June 23rd to 25th in San Diego, and you can find the schedule, speaker list, and all things FACTO on our website. And super exciting this year, it's new, we're offering some wellness programming for patients and families who need a break from the scientific sessions. But for those of you who just can't wait for the scientific presentations, we will have some amazing speakers lined up, including our guests today, Dr. Huang and Dr. VanHeyst. Our panel topics this year are targeted therapies, immunotherapies, big data, liquid biopsies, clinical trials, local control, improving existing therapies, and supportive care and survivorship. And we're excited for great discussions on the panel and in the meeting room. But the truth is, a lot of the magic happens outside that conference room. Never underestimate the power of a cocktail with colleagues to get the creative and inspirational juices flowing, and a passionate and supportive patient family community that will give you a turbocharge. And speaking of turbo, for any clinicians joining us today, MIB Agents hosts a bi-monthly virtual tumor review board for osteosarcoma called Turbo. The next one is Wednesday, May 11th at 5 Eastern. If you'd like to be added to the calendar invite or have a case to submit, please let us know, and we'll put a link in the chat where you can request more info. And now I'd like to hand it over to Matt, if you could introduce yourself, and I think you also have an announcement.
Yeah, definitely. Thank you. My name's Matthew Allen. I'm currently a second-year student at the University of Michigan studying political science and philosophy. I've been on MIB's junior board for 2 years now, and I've also been involved in their Gamer Agents program. So I'm just really excited to be here, and thank you, MIB, for having me. But before we get started, I have a little announcement that I think a lot of you will be very excited to hear about. Next week, instead of our usual OsteoBites, we're excited to announce the April 28th debut of MIB's new podcast, Osteo, that's with a capital TEA, where osteo warriors in treatment and recent survivors spill the tea on osteosarcoma from the adolescent and young adult patient perspective. Listen in on their honest and personal conversations about their osteo experiences, stories, and who knows what else. Find Osteo on the MIB channel on your favorite podcasting platform.
All right, thanks so much, Matt. And then Dr. Huang, if you want to go ahead and bring up your slides, I think we can go ahead and get started.
Well, thank you so much for this opportunity to again share our update to the MIB agents community. And last time I spoke, I think it was back in September, and I knew it did such a terrible job. But today I needed some backup. So today Dr. VanHeyst is here to make sure that I'm saying everything correctly. It's just been a pleasure to be working with Kristen over the last few years, and learning a lot from her as we go through this process of bringing up clinical trial concepts in metastatic refractory osteo. Kristen, you want to say real quick? Just want to say hi to everybody before we launch into it.
Hi, everybody. Thanks for inviting me as well, even though Dr. Huang is the man behind the magic, but I feel very blessed to have the opportunity to be here with him. So thank you.
So great, thank you. I think our time is short, so I'm going to launch right into it. We have some disclosures because we'll be talking about off-label use for products from Biogen, as well as a developing product from Mapekto. Here are disclosure information. And what I will discuss today are actually direct results of the outsmarting osteosarcoma grant that we received back in 2019. And just wanted everybody to know that your money does result in tangible outcomes. And not what we've done today would not have been possible without your support. So thank you very much. So historically, we have been very interested in understanding why tumor form and their potential tumor intrinsic vulnerabilities that we can target. And this is the basis of many of our current therapeutic options, looking at chemotherapy, radiation, and others that are targeting, for example, genetic alterations, cell cycle progressions, how cells make proteins and turnovers, and metabolic pathways, nutrient responses, and stress. However, as an immunologist, I've been very interested in understanding whether or not there are tumor extrinsic vulnerabilities that one can target that will result in similar, if not more efficacious outcome in cancer therapy. And what we've been focused on is immune suppression, invasion, resistance, the idea that our body's immune system, when properly activated, can be used to fight cancer effectively, if not more, than other traditional methods. And so the immunotherapy promise really is multiple fronts, in that it can be very powerful, it can be universal regardless of the tumor types. There are some synergistic effects that immunotherapy can behave in the face of other traditional therapies, can be highly targeted. It can distribute throughout your whole body, and you can adapt over time potentially, and also durable in some of our clinical experiences so far. When we think about tumor, I think very often we think about a biopsy of a tumor, thinking that most of our biopsy samples consist of tumors. In fact, in a tumor mass, yes, certainly the tumor cells are there, but they're also comprised of many other cells derived from the host, and principally from bone marrow-derived and stroma-derived or endothelial-derived cell populations that comprise the entire microenvironment of the tumor. And specific populations within that microenvironment, including macrophages, dendritic cells, or MDSCs, or myeloid suppressor cells, the so-called myeloid cell populations derived from your bone marrow, we believe have very important role in whether allowing tumors to progress or disrupt tumor growth when properly activated. And in fact, this issue of myeloid cell in a tumor microenvironment is more pertinent, especially in pediatric population. It turns out that compared to adult population, pediatric tumors comprise more of these myeloid cells, as denoted here by CD68 as a marker, and where in comparison, adult tumors tend to have more T cell infiltration. And it's been shown by Richard Gorlick and others that in osteosarcoma, for example, the more you have of these infiltrating macrophage populations, the worse outcome you have in terms of disease progression. So what it suggests is that these myeloid cells in your tumor pertains to a worse outcome and potentially setting up an immune suppressive microenvironment to allow the tumors to grow. And so, and this is further demonstrated last year by this study from the POB at NCI, by Rosie Kaplan's group, showing that if you take these myeloid cells and ex vivo or outside of the body, manipulate them into a super functional myeloid cells, you can actually achieve tumor regression in mouse models of rhabdomyosarcoma, further indicating the importance of these myeloid cells and their determination of the ultimate outcome. So we want to spend today in the next half an hour to update you on two principal therapeutic concepts that are derived from this whole targeting of myeloid cell biology, and as well as other tumor intrinsic, extrinsic pathways. The first one is the interintegrant therapy. And this particular project focuses on the idea that tumors don't exist alone by themselves when they thrive in the body. They need to recruit neighbors to allow them to set up a niche that is conducive for their survival. And what we have found over the years was that as opposed to the primary non-metastatic osteosarcoma, there are certain cells that metastasize either to the bone or to the lung. These cells are able to do so overexpress on their surface this molecule called VCAM1 or CD106. And this is a molecule that normally is expressed in many of your endothelium that allows immune cells to actually transmigrate from the blood vessels out into the tissue. But for whatever reason, metastatic osteosarcoma, and now is also being shown in breast cancer and cervical cancer and leukemias, that these certain populations of tumor cells overexpress this surface molecule CD106, and it allows them to survive better in a metastatic niche. And we wanted to understand that a little bit more. And again, these are based on some prior studies in breast cancer and cervical cancer, showing that this VCAM1 is a relevant target. We looked at osteosarcoma in human samples. They're overexpressed in majority of the samples that we've looked at, both in TCGA data sets as well as the St. Jude data set. We went back to actually using preclinical mouse model and to ask the question whether this VCAM1 overexpression truly exists in some of our models we have available in the laboratory. A very well-known and well-used osteosarcoma model is the K7 model, which is derived from the white mouse, the BELPC mouse. It has a subline that's highly metastatic K7M2. So you have the parental non-metastatic K7 and the metastatic subline K7M2. When you inject these cells into the bone of the recipient animal, the K7M2, as the name suggests, are highly metastatic. They will set up the metastatic lung niche and eventually kill the animal because of metastasis. When we looked at the difference between K7 and K7M2, what we found was that in the K7M2, the metastatic subtype, it highly expresses this VCAM1 or CD106 target that I talked about earlier. And this can be demonstrated on the surface of these tumors. These tumors, when they're injected into the animals, set up shop in the lung more efficiently than K7. And if you somehow genetically delete this VCAM1 expression on K7M2, you render K7M2 from a metastatic phenotype into a non-metastatic phenotype. So they don't survive in the lungs anymore, suggesting that this molecule VCAM1 on this K7M2 tumor plays a very important role in allowing them to survive in a tumor microenvironment in the lungs. We then asked the question whether or not this VCAM1 expression on the tumor is directly speaking with a neighboring cell called macrophages, which are highly abundant in the lungs, via other receptor integrants called alpha-4 beta-1. And we have done so by basically a brute force, that is to use chemical to deplete macrophage population from the animal. So take away this enabling neighboring cell completely and ask whether or not the same tumor now, when injected into the animal, can survive and thrive in the lung. And the answer was no. So, this is a busy slide, but what we show here is that if you were to use these chemicals to deplete macrophages in the lungs, you can render the animal they're injected with tumors 100% tumor-free. And so it suggests that the presence of the macrophages in the lungs are highly relevant and important for the survival of metastatic osteo. And this is shown not just only by our laboratory, but others, including the Ohio State and other places, have shown the importance of macrophage population in controlling the tumor microenvironment and the tumor growth. And so obviously your macrophages are important. So what we decided to do is, can we just functionally disrupt this interaction between VCAM1 and alpha-4 beta-1 between the tumor and the macrophage? And it turns out that there are available agents out there, whether it's antibody-based, so you have antibody that recognizes the alpha-4 portion of this alpha-4 beta-1, and thereby disrupting VCAM1 interaction with the alpha-4 beta-1, or a synthetic peptides that mimics part of this interaction domain. And in both cases, we are able to disrupt established tumors and causes spontaneous regression when we administer either the antibody or these peptides by disrupting this VCAM1 alpha-4 beta-1 interaction. And that really is the basis of the clinical trial that Kristen is going to talk about. It turns out the alpha-4 antibody in the human form is already FDA approved. And it was approved for the treatment of multiple sclerosis and inflammatory bowel disease because the same target is also used by pathogenic T cells in patients with autoimmune diseases to allow them to enter into the CNS or in the gut. And by using the antibody, they can disrupt the entry of these pathogenic T cells into the gut. So it's the same target, but it was approved for different indication altogether. And this is just to further demonstrate that, in fact, when you disrupt these interactions with the antibody or with genetic manipulations, you in fact cause a lot of changes in the tumor microenvironment that explains why the K7M2 now all of a sudden do not thrive in the presence of these therapeutic manipulations. And that included changes in the immune cell population, such as increase in NK cell, or decrease in the myeloid suppressor cells, or changes in the production of arginase 1, an enzyme that is known to cause immune suppression in the tumor microenvironment. And so I will hand over to Kristen to talk about, based on these data, we approach Biogen, and then what happens, the saga that we had with Biogen for the last 4 years.
Okay. So as Dr. Huang mentioned, he and I have known each other for quite some time. And when I was a fellow here at this institution, during my fellowship, I had joined Dr. Huang's lab, and this was like my primary interest. I wanted to do translational work. And so this is the trial that we came up with. And it's a phase 1/2 trial using Natalizumab, which is an anti-alpha-4 monoclonal antibody, to treat children, adolescents, and young adults who have recurrent refractory or progressive pulmonary osteo. And for the reasons that Dr. Huang had just mentioned, we had enough preclinical data to basically support the development of this trial. So the study design in brief, it's a single arm trial, meaning that all patients who are enrolled in the trial will get Natalizumab. It's an open label proof of concept trial, so there's no randomization. Patients and as well as the physicians treating the patients know that they're getting Natalizumab. The study design is a 3x3 design, which means that for the phase 1 portion of the study, our primary objective is to evaluate the safety and tolerability of Natalizumab. That's the primary objective of all phase 1 studies. So because Natalizumab is not approved for our patient population, we will have 3 basically cohorts of 3 patients each that receive a dose of either 2 milligrams per kilo, 3 milligrams per kilo, or 4 milligrams per kilo of the drug, not to exceed what the already FDA approved adult dosing is, which is 300 milligrams. The drug is currently FDA approved for the treatment of multiple sclerosis and Crohn's disease in adults. And so the primary endpoint for the phase 1 portion of the study is therefore dose limiting toxicity. And once we establish what a safe dose is for our patients to receive, those patients can proceed on to the phase 2 portion of the study, which is really looking at that point for efficacy. And so that's assessing clinical response as well as overall survival. And we plan to do that with imaging, primarily CT imaging of the chest every 3 cycles, where a cycle is defined as 28 days. Natalizumab is given as an IV infusion on the first day of each cycle, and it's a 1-hour infusion. Our correlative objectives for the study is, as we've mentioned, VCAM1 can actually be cleaved from the endothelial surface to a soluble form. So this is known as soluble VCAM1. And the expression of soluble VCAM1 has been shown to be elevated in the peripheral blood of patients with a variety of malignancies compared to healthy hosts. And so our goal is to evaluate soluble VCAM1 expression in the peripheral blood of patients every 3 months to see if in fact the expression is higher and then decreases over time with the treatment of Natalizumab. So as Dr. Huang also mentioned, this took us a very long time to bring about, primarily because at our institution, we didn't have a dedicated pediatric clinical trials unit to help us push through pediatric and AYA trials. But now the good news is that we do. And so we're able to get trials really kind of up and running rather quickly. So we got protocol review and monitoring committee approval for this in 2018. Because this drug, as I'll go into in a little bit, is not available off-label because it has a black box warning, Biogen had to agree to allow us to cross-reference their IND so that we could apply for our own FDA IND. And thankfully, they did allow us to do that. And so that happened in 2019. All of our contract finalization took several months with Biogen. We applied for FDA investigational new drug approval, and we got that in December of 2020, right around Christmas. So that was exciting. And then the last step was we needed IRB approval for the trial at our institution. And then we're very excited to share that last month we actually opened the trial to enrollment. Okay, I said a lot, I'm sorry. As I mentioned before, Natalizumab, also known as Tisabri, is manufactured by Biogen. The numbers above that are just the 1718 is the number that Case Western University, where we are, gave the trial at our institution. And then the number next to that would be the identifier that you can look up the trial by on clinicaltrials.gov. Natalizumab is a recombinant humanized monoclonal antibody. It binds to the alpha-4 subunit of both alpha-4 beta-1 and alpha-4 beta-7 integrin. It's currently FDA approved for the treatment of MS and Crohn's disease in adults, but there has been safety shown in pediatric patients with MS. Most of the patients had only transient side effects if they experienced any at all, and those included like headache, upset stomach, some nausea, but the patients that were treated with MS that were of pediatric age all actually received the adult dosing of 300 milligrams, except for one patient who was less than 45 kilos. And those were just studies that were done pretty much all throughout the world. There were Italian studies done in Kuwait that I had kind of gathered to look at the safety profile, at least in pediatric patients. I think we're good. Okay, so as I mentioned, a lot of this is going to be a review, I suppose. The phase 1 portion of our trial is looking to evaluate the safety and tolerability of Natalizumab, specifically in children, adolescents, and young adults who have pulmonary osteosarcoma, because that has not been previously established, because it's only been established for adult patients with those two diseases, MS and Crohn's. The phase 2 portion of the study, the primary objective would be to evaluate the overall clinical response for patients who are being treated with Natalizumab on the study, with a secondary objective as to what their overall survival is. And then, as I mentioned, one of the correlative objectives is for us to perform ELISA testing in the lab on peripheral blood samples from each patient every 3 months. So every 3 months on the study, they'll be getting labs drawn anyway, basic blood work that patients routinely get when they're receiving some form of immunosuppression. And so this would just be a small amount of additional blood for our purpose. So who are we looking to enroll? We're looking to enroll patients between the ages of 5 and 30 years of age. They have to have histologically confirmed refractory or relapsed pulmonary osteosarcoma that is unresectable, because the standard of care for pulmonary osteo that is resectable is to actually resect the lesions. So if a patient has some resectable disease and also has unresectable disease, we will permit them, of course, to have the lesions that can be removed. And then if they still had some remaining, they would be eligible for the trial. They have to have progression of the disease on systemic therapy. So this can't be used as a first line agent. Certainly they have to have failed other standard of care modalities, and they have to have measurable disease per the RECIST criteria, which we use to basically then determine how a patient is either improving or progressing on the trial. And because we don't know if any effect that the natalizumab would have on a patient, we hope to have patients at least on the study for 6 months. So even if after 3 months, if they are otherwise well, but their scans are not showing improvement, but stable disease, or even if the disease looks like it may have slightly progressed because of some inflammatory responses that can occur when somebody is receiving immunotherapy, we would permit them to remain on the study for another 3 months, so for a total of 6. And then at that point, if someone is going to respond to the natalizumab, we should know that by that point. So this is just a little schematic of our trial design. Natalizumab is administered the first day of each cycle, plus or minus a few days. It's given as an IV infusion over 1 hour. And the patient does not need to have central line for it. So I think that's something to point out, because it can just be given through a peripheral line if the patient's had their central line removed. The cycles are 28 days in length. And so every 3 cycles, we plan to do our correlative studies, which are the peripheral blood, which is the peripheral blood testing for soluble VCAM1 concentration, as well as CT imaging of the chest. We do, or we will rather, get a PET scan initially up front, so that if something is not able to be determined as to whether or not it's disease moving forward, we have something to compare it to based on a PET scan that was initially done before the patient enrolled on the trial. And then the only other thing that we will include in there, which we'll get to, I think, in a minute. Oh, here we go. Perfect. Is the black box warning. So the maximum duration that we plan to have patients on the study, hopefully, because they're doing so well, is 24 months. And the reason for that being is that natalizumab has a black box warning. And the black box warning is that patients who receive natalizumab are at a higher risk for the development of something called progressive multifocal leukoencephalopathy, or PML for short. Yeah, I can't even remember it half the time. PML is basically a progressive, oftentimes fatal disease, most of the time a fatal disease, where the patient has changes to the white matter of their brain. And so risk factors for the development of PML is the duration of natalizumab therapy. So in prior studies that Biogen had done, they found that the risk increased if a patient was receiving the drug for longer than 24 months. If the patient has had prior use of immunosuppressants, which all of our patients will have previously had, so that's a risk factor for everybody. And then the presence of something called the JC virus antibodies. So JC virus is actually something that's rather common. If you look it up, the majority of the population will have antibodies to it. And so reactivation of those antibodies can actually lead to an increased risk for PML. So the way we plan to monitor for this is to test all patients for JC virus antibodies prior to enrollment on the study. If they are positive, because the majority of the population will be, we certainly don't want to exclude them, because then we'd have nobody to enroll on the study potentially. But it would help guide further discussions with the patient and the patient's family as far as understanding risk factors. For patients who are JC virus antibody negative, and have not previously received immunosuppression, the risk of developing PML is 1 in 10,000. But if they are JC virus antibody positive and have received immunosuppression before, then the risk is 1 in 1,000. So it increases substantially, even if you're looking at just 1 in 1,000 as not many. So the other way we plan on monitoring for this is for patients who have compatible hardware, because a lot of our patients, probably due to original site of disease, et cetera, may have metal hardware within them. If it's compatible with an MRI, we will also do brain MRI imaging every 3 months, because sometimes you can actually detect the changes in the white matter of the brain before the patient becomes symptomatic from having PML. And then at that point, you could abort the study and the treatment further for the patient and may have a favorable outcome. Unfortunately, for patients who do not have MRI compatible hardware, they would not be able to receive an MRI. And then there is no other better way to assess for PML development. And so in that case, we will just educate families when they enroll in the trial what the risks are for that development. But this is why we needed Biogen's approval to cross-reference their IND, and we couldn't just like get the drug on our own. I think, yeah, okay.
Okay.
Maybe I'll pause. Is there any questions about this first half of what we are discussing from the audience?
Yeah, if the audience has any questions on this trial before we move on to the next, please feel free to put them in the Q&A. And then maybe I have a few questions, and Matt probably does too, but just some eligibility questions. What's the washout period, or how long do you have to be off therapy before enrolling in the trial?
Kristen?
That's a good question. It depends on what therapy the person has most recently received. So because monoclonal antibodies are kind of out there floating around and people are using them as treatment for patients after they failed MAP therapy or IFOS and etoposide, et cetera, the washout period for that is 3 half-lives. Most of those drugs have a half-life of about 28 days or so. And so you're looking at close to 3 months for that. But it really depends on what the patient has gotten. If they've just had myelosuppressive chemotherapy, then they just have to have adequate count recovery from their prior treatment prior to enrollment on the study. But that's pretty much the only 2 caveats that we have.
Got it. So sorry, just to make sure I didn't miss it. So so let's say if it's like a TKI or something, that would be about 3 months.
No, that would actually be shorter.
Shorter?
I mean, we don't actually have a stipulation for that, to be honest. But if someone's on like a TKI, for example, that's just like usually no time at all, the half-life of that to begin with. So by the time the patient probably had their pre-screening evaluation done with us and got the drug, it would have already been out of their system.
Okay.
It's more for you, somebody getting anti-GD2 or anti-CD47 antibody-based therapeutics.
Okay.
Then, yeah. Okay, so is it okay if we move on to the next, so we don't make sure we're okay on time?
Yes, let's move on to the next, and then we can get you with questions at the end.
So I just want to quickly update everybody on another line of investigations that Kristen and I have been doing along with folks in the laboratory, and that is this orally bioavailable inhibitor of TGF-beta receptor called vectosertib, or TW7197. And this is targeting a very important cytokine pathway in the tumor microenvironment, specifically osteosarcoma and other sarcomas as well. TGF-beta, which is a known immune suppressive molecules that enhances the regulatory T cells, myelosuppressive cells, enhances the tumor-associated macrophages that are immune suppressive. And we find out that it also supports the tumor growth intrinsically of osteosarcoma. So inhibiting this pathway is very important. And I think historically, it's been multiple failed attempts and using antibody-based therapy against the ligand, TGF-beta, and others. And for reasons we don't have time to go into, we're very intrigued when Mapekto in South Korea developed this orally bioavailable molecule, small molecule inhibitor for the receptor of TGF-beta. We're very intrigued by its biology and the non-toxic nature of its early clinical trial experience in adult cancers. And so we approach them and say, listen, can we establish a collaboration with you to just look at your drug's effect on osteosarcoma. And that was about two years ago. And this drug, vectosertib, has a very interesting pharmacokinetics. And that is, you can take this by mouth and you can measure peripheral blood in terms of the amount of TGF-beta signaling activity. And this can be measured by phosphorylated SMAD2 or 3 status in peripheral blood. And under normal circumstances, when you have TGF-beta around your body, and there are plenty of TGF-beta in platelets, for example, and your body's TGF-beta pathway is on, and this is signal. You can see this as being very high in saturation of phospho-SMAD2 and 3. But upon taking this oral pill, within 2 hours or so, you effectively suppress the phosphorylation of TGF-beta signature below 10–15%, and that persists for the next 24 hours. And by 8 hours, you virtually have shut down the entire TGF-beta signature by taking this orally. But within 24, you have recovery of this drug. Within 48 to 72 hours, the drug effect is completely out of your system. So as opposed to antibody-based therapy, we have an oral agent that you can titrate to effect. If there's any untoward side effects, you can stop the agent within 72 hours. You can be pretty sure that the drug will be washed out of your body. And this is just the picture here on the right is very busy, but to show that among mouse and human osteosarcoma cell lines, we see that addition of TGF-beta hyperphosphorylase, the TGF-beta signature pathway, and the addition of TW drug, as well as 100 nanomolar, can shut down the TGF-beta signature or pathway very significantly, including some of the MYC amplified cell lines, 143B. So we know the drug is hitting the target. In vitro, you can treat osteosarcoma cells, both mouse and human, and show that within, on the range of 1 micromolar concentration of this drug or so, you can shut down proliferation of osteosarcoma very effectively in most of the cells. There's some cell lines, for example, 143B by itself, it's unable to do so. And we are trying to figure out in this particular cell line, as opposed to other cell line, why this cell line is resistant. And part of it might have to do with MYC expression. It's interesting that the TGF-beta inhibition in other osteosarcoma cell line actually very avidly shut down c-MYC, the protein expression in the osteo, which we know is important for osteosarcoma. And we know that the drug effect on the osteosarcoma can disrupt its proliferative potential, having effect on PI3 kinase pathway, mTOR. And most recently, we also found that in the MYC-driven expressions and pathways is highly regulated. So we took this drug and then actually performed some in vivo experiments to show that in human osteosarcoma, when we inject it into an immune deficient mice, so to interrogate whether the drug has a direct effect on the tumor itself, either we treat it early on after implantation of tumors or very late in the disease course when the tumors are very large in size. In both cases, administration of this oral agent by gavage can very substantially reduce the tumor burden and overall tumor survival, increase the tumor survival in animals that were treated either early or late in the disease course. Similarly, we have also done it in syngeneic mouse models, so we can actually interrogate the effect of this inhibition of TGF-beta, not just on tumor cells themselves, but all the changes in immune-regulated microenvironment. And what we show is that, again, we can very effectively treat tumors that have spread to the lungs. And after injecting the tumors into mice, we start treating the mice after 4 weeks or so, at a time when the lung tumor burden is quite extensive. We can render some of these animals completely tumor-free in our experiments, solely as a mono agent with monotherapy. And what we saw was accompanying upregulation of CD8 T cell activity, NK cell, and some of the more functional macrophage populations, implying that this monotherapy has changed the tumor microenvironment to the point that they're effectively overtaking the tumor and render the mouse tumor free. We've also trying to, sometimes inconsistently, but seeing some synergistic effects, combining TEW with immune checkpoint blockades, in this case anti-PD-L1. And so we're doing more experiments now, but in many of our cases, actually, what's surprising to us was that monotherapy, but TEW by itself can be equally effective as combining with immune checkpoint blockades. And so we provided these data to the company last summer. They applied for an orphan drug designation application with the FDA for the treatment of osteosarcoma. And we were granted that orphan drug designation in late August. And this obviously gets the company very excited. And maybe, Kristen, you want to talk about both on the compassionate use cases as well as the upcoming clinical trial we are scheduling with or planning?
So as Dr. Huang mentioned, we're busy with Mapekto in developing a clinical trial using Vactocertib for patients with osteosarcoma. Currently, I've written the trial with Mapekto, and we're going back and forth to decide final and formal details. So this is just sort of a preview for you guys, but we're hoping to enroll patients as with a lower age limit of 14 and up, with no specific end age upper limit. Currently, they have not ever given the drug to children before, except for on a compassionate use basis, which we'll get to in a second. So they felt certainly more comfortable not lowering the age limit right at this time, but we're still in negotiations with them about that. The drug is orally given. It would be just done as monotherapy for now, because we're currently doing more experiments in the lab, as Dr. Huang mentioned, in conjunction with anti-PD-L1. So we first need to ensure that that has some sort of synergistic effect, and then may consider doing that as like an additional arm on the trial at some point. But for right now, the trial would just be monotherapy. It would be Vactocertib. It's given orally. It's given 5 days in a row, 2 days off. It has very minimal side effects. Most of the side effects are extremely well tolerated by adult patients who have gotten it for a variety of malignancies in their clinical trials. And the company is very enthusiastic about it and about helping patients as well. So hopefully that will be coming down the pike soon. I think it's also important to mention that while the Natalizumab trial is solely for patients with pulmonary osteosarcoma, we would enroll patients with just osteosarcoma in general on this trial. It does not have to specifically be pulmonary disease, so they can have disease in extrapulmonary sites. And then the goal is that we would hopefully open this trial up when more of the minute details are ironed out, to patients potentially with other solid tumors. So not just osteosarcoma, but other pediatric and AYA tumors as well. So we've worked with the company now twice to get Vactocertib for compassionate use for patients. One patient had received Vactocertib. She was an adolescent patient who had diffuse disease. And she unfortunately passed away about 2 weeks after starting Vactocertib. But at that point, her disease was also very robust. This patient that I'm going to tell you about is actually at our institution. And he is a 13-year-old male now, but he was originally diagnosed with osteosarcoma in the right distal tibia when he was, I want to say 8 or 9. He is status post a below the knee amputation of that right leg, but since that time he's had disease relapse many times. In his lungs, he had a mediastinal mass, he had a left temporal mass, and most recently he had a right gluteus minimus mass. So the therapies he had gotten to date, he got standard MAP chemotherapy. He's had lobectomies because of the tumors in his lungs. He's received palliative radiation to the mediastinal mass. He's also gotten Doxil and temsirolimus. He's also been on regorafenib in the past. He also got temporal radiation for the mass in the left temporal region. And most recently, he underwent resection of his right gluteus minimus mass. However, that recurred. And so this patient is otherwise, despite his recurrent disease, is otherwise actually very healthy. You wouldn't know it to look at him other than that he has an amputation and wears a prosthesis, but he goes to school, he has great organ function. And so when his mom and dad approached us about what could we potentially give him now, given that he otherwise has great organ function and disease only in one site, unlike our previous patient who had received compassionate use of the drug, we decided that this may be a good option for him. And so Mapekto worked very closely with his primary oncologist and with us to get him the Vactrosartib. I think, do we have another slide, Dr. Huang?
Yes.
If not, I remember. Okay. So he got the Vactrosartib right after he received radiation therapy for the recurrent gluteus minimus mass in February. And so I actually saw him myself on Monday this week because his primary oncologist was out of town, and he is doing very well. He has not missed a beat or skipped a beat. He's still going to school. He has no side effects except for the fact that he has a slightly prolonged QTC on his EKG. But apart from that, he's not symptomatic from it. And we just monitor him monthly, and we want to make sure that we're not going to give him other medication that could potentially prolong that further, but he doesn't need any other medication. So as far as how he is doing with taking the drug, he's doing very well. His repeat imaging to monitor his disease status, however, is planned for next month. So we don't know if the Vactrosartib has actually helped or not with respect to his osteosarcoma, but as far as tolerability, he seems to be tolerating the drug just fine.
Thank you. Obviously, we have conveyed the patient's update to the company, and they're very excited about, at least from the tolerability and toxicities profile, very encouraged by it. And we'll see what the scan shows next month. But because of that, actually, they re-sparked the whole conversation with Mapekto, and they really want to push this phase 1 trial ASAP. And they were asking us as of earlier this week or last week, how quickly can we get to the IND stage? And so I think we made a promise of 6 months. And so I think it's all hands on deck to make this a reality quickly. So I know our time is short. This is just a recap of what we discussed today about these 2 trials. I'm hopeful that the second project, with Kristen's help, we can make it up and running. Really, I think I wanted things done yesterday. So, we wanted, the goal is to have by the end of 2022, something that's tangible and offer. And the company has, financial piece. I think they have sort of give us a wink and a nod that something's going to happen on the financial side, as opposed to the integrant therapy earlier. The reason it took so long is we got to fundraise these myself. To fundraise the whole phase 1 trial by myself. I've never done it before. It's a great experience. I don't recommend anybody doing it. So, so the last couple, just 1 minute. I know last time I mentioned about BG34. This is the O brand derived beta glucan compound. This is still on trial, on pace to have a osteosarcoma canine trial. This is because of the FDA, our conversation with the FDA. They wanted to see a large animal safety profile. So this will be targeting pet dogs with metastatic osteosarcoma, and this will be conducted through the NCI and University of Pennsylvania Veterinary School. We have an ongoing project which has been written up about the effect of cryoablation on sarcomas and the molecular determinants of that, trying to understand why it works and why it doesn't work in sarcoma cases. And then the third project that I don't have time to talk about, we have begun a conversation with a company that will use autologous NK cell therapy for sarcoma, for relapse refractory sarcoma. So all these things are coming up, and I hope by the time we come on again next time, I don't know what that's going to be, but at least we can give you an update on a more positive update on vectosertib, and then hopefully by then the canine trial will be also up and running. So as Kristen mentioned, that we never know what you get yourself into, but we propose this concept for Center for Immunotherapy. There are now clinical trials rolling off from this virtual center. We are now actually engaged also for gene therapy for hemophilia and sickle cell disease, all with the confine of this Center for Immunotherapy. So stay tuned, and thank you for MIB agents, but we also been buoyed by I'm just blown away by the amount of foundational support that I'm looking at these logo, and I feel like we got to start wearing these Formula One jackets with every foundation's logo on. It's just fantastic, and thank you all for your really for your confidence and your support. It means a whole lot to Kristen and myself. So thank you very much.
Thank you so much. We're going to probably do some rapid fire questions at you. I know we have a couple from the audience. Matt, do you want to go ahead? And
Yeah, definitely. We have a question from David in the chat who asked, are there any other monoclonal antibody drugs that could be used with similar impact, or is Natalizumab, I have such a trouble saying that, I'm sorry, unique?
Kristen, you want to mention some other therapy?
Sure, I can mention it. You'll correct me if I misspeak. So no, unfortunately, Natalizumab is the only drug that we have available clinically right now. That's an anti-alpha-4 monoclonal antibody, which is why we're sort of stuck using it despite its black box warning. And in fact, we're currently writing a review article, and in reviewing other articles, even written like a decade or more ago, people are talking about, oh, there's this drug, it's called Natalizumab, maybe it could possibly be used someday, but there was never anything to like concretely support its use. And so it's kind of cool to be reading that and saying like, oh, but maybe we did. So unfortunately, no, it's just Natalizumab for now.
Okay, thank you.
And another question that came through is for the case that you mentioned with the 13-year-old receiving the vectosertib, was there, do you have any info on their genomic sequencing?
So he's not my primary patient, even though I have known him intermittently for a couple of years. I am sure his primary oncologist did genomic sequencing on him back when, but I don't believe any has been done recently. I know that Mapekto, the only information we've collected for them from him is just pharmacokinetic and pharmacodynamic data through blood work, but I don't believe he's actually had genomic sequencing done, at least not with this new recurrence.
That kind of leads me to my next question, just kind of thinking about if I was a patient considering both of these options. So the Natalizumab trial is currently open. Vectosertib isn't open, but it sounds like it's available via compassionate use, potentially a patient could access. And so, I think you said, well, I mean, since Vectosertib isn't actually a trial right now, it would be compassionate use. What are some other considerations for a patient when they're thinking about like, should I consider the Natalizumab trial, or should I consider compassionate use Vectosertib?
So I think one would be certainly like what their disease burden is, as well as where the disease is located, because obviously that might preempt them from being from receiving Natalizumab in the first place. I also think it depends on what is more comfortable for the family. We have had so many inquiries about the trials, or the Natalizumab trial and then impending trials from around this country. We've even had inquiries from the UK. And so since it is a single site trial right now, Natalizumab, families have to travel here to get the drug. Now, thankfully, it's only once a month, but even still, that may not be something that a lot of families can do. even though we do have some resources in place for hotel stays and things like that. So I think it depends on just like what is comfortable for the family, as well as what the disease is in that particular patient, and overall just well-being in general. I don't know if Dr. Huang has any other thoughts, but.
No, but I think the comforting side about the vectosertib is the company has shown a great deal of faith and willingness to actually help out locally with patients who are not necessarily here, right? So, you know, and for those who are interested, you know, we're happy to supply the data to help your primary oncologist to talk to the company and strategize from your local institution how to get this drug into your child. And so, you know, we're happy to do that. I think obviously running a clinical trial with Natalizumab where everything's done here locally, as Kristen said, you know, it's sometimes it's great for in terms of our ability to kind of monitor everything, but you know, for many patients who are coming from out of state, there may or may not be a undue burden, and they might want to stay locally where they are. And so those are kind of a consideration. But you know, obviously, again, you know, if you have multiple site disease outside of the lungs, then you know, Natalizumab, as we have shown already, is not as effective against non-pulmonary mets as they are in mets. So.
Okay, that's helpful. And just a quick follow up on that. So 2 things. We had Elena Gerasimov from Kids v Cancer on Osteobites a few weeks ago, who actually walked through the whole compassionate use process. So for those of you currently on, we'll make sure we provide that information in the follow up. And for the Natalizumab trial, it is local at UH, but for things like scans or labs, can that be done at the patient's home hospital, or do they need to be at UH for that?
So there are labs that are done mid-cycle, and those can be done at the patient's home hospital. We would just arrange to get them. But the scans and the other labs are actually timed in such a way that they are given or done at around the same time that the drug is given. So they would have those here.
Okay, great. Thank you.
I guess I just have one question. I was thinking during the time where you were talking about all the steps you had to go through to get approval for the trial, what other factors can influence how long it takes to get approval for the trial? I know you were talking about with the brain issue that happened, how that like kind of introduced another aspect, but what other factors can have an impact? I
think as with any trial, having the pharma company who has the drug to be interested in a trial with osteosarcoma is always a challenge. I found it kind of interesting in that dynamics for a variety of reasons. So, you know, one challenge is to get a private industry interested in the issue that we're discussing here. But then other issues pertaining funding, you know, it all depends on the arrangement, because it does cost a lot of money to run a clinical trial, and as a big institution as ours, they don't just hand out money like, you know, here's the money, you go do a trial because it's for the good of children. I mean, that's not how people operate. So the first question they always ask us is, do you have the money to run the trial? We have to pay the hospital to run the trial. So you know, obviously, if you have a pharma company that's interested in sponsoring your drug, they may provide the funding, but at the same time, they may say, well, we're going to run it as a pharma company sponsored trial, and they have a lot of say in how the trial should be done or where it should be done, as opposed to a investigator-initiated trial, meaning investigators, Kristen and I, who go to their company and say, hey, we want to run this as a investigator-initiated trial. Very often they say, oh, good luck. Here, we can give you the drug for free, but everything else, the hospital stays, the infusions, all the costs, good luck in trying it. So a lot of it's financial, but sometimes also the regulatory, as Kristen mentioned, you know, depending on where you are. Some children's hospitals are better at doing this. In big health systems, when you have resources, there's centralized clinical trial unit that's divvied up between adult trials and pediatric trials. Very often you have to fight for resources for people to help you on trials that we may or may not recruit a lot of patients. And I think there's some financial considerations into resources. They want to do trials that have a lot of patient recruitment and the hospital can recuperate. And so as a result, many of our trial concepts kind of get pushed to the background and say, you know, when we have time, we'll help you. And that was our experience with Natalizumab. I mean, the first time we approached them, they say, you have to wait for 2 years before we talk to you. I said, that's unacceptable. And this is why we say we got to have our own people. And yeah, so there are a lot of different, you know, but I think the more challenge there is, the more psyched Kristen and I are. We look at each other like every day, like, what are we doing here? We just keep pushing. Here we are.
Yeah,
well, I'm
you.
glad you both continue to charge ahead. This is super exciting, and thank you for talking about two like amazing, potentially promising therapies. And I'm sure there might be some folks that still might have questions. And would it be okay if they have questions, we can share your contact info if they have additional questions about eligibility? They can
Absolutely.
be in touch. Okay,
Yeah,
great. So we'll make sure that we share that in our follow-up to all of you who registered and are attending today. And we're at the end of our hour, but I want to thank you both so much for spending today with us and for, as always, making it better with all your work. And more information on this and all Osteobites can be found on YouTube, on our website, or your favorite podcast place. And next week, instead of our usual Osteobites, like Matt said, we are going to have our new AYA podcast, Osteo. So tell your kids and patients it's going to be a lot cooler than Osteobites. Not that we aren't cool, but it will offer a whole different perspective on dealing with osteosarcoma from AYAs who are living through it. We'll be back though with our usual Osteobites programming on Thursday, May 5th, and you won't want to miss Dr. Corey Painter from the Broad Institute, and she's going to be giving an update on the osteosarcoma project. Thank you again, Dr. VanHeyst and Dr. Huang, and thank you, Matt, for joining us today. Thanks to all of you for spending an hour with us today, and we hope to see you on May 5th when we chat with Dr. Painter. And make sure you check out the Osteo podcast dropping next week. All right, thank you so much.